I'm Donald Abrams with Clinical Compensation Consultants, and we're going to talk about atmospheric barotrauma. We're going to discuss causes, symptoms, and treatment, and most importantly, all the pertinent data you need to obtain at the initial onset of this claim, as well as going forward through the waypoints, if you will, in this claim. So let's start out with a basic definition of barotrauma. Barotrauma is also known as aero-otitis or barotitis. And basically, this is a compromise to the structures of the inner ear. As we'll see in a moment, the ear has the canal, the tympanic membrane, the structures behind the eardrum, and the nerves that go to the brain to facilitate hearing. In this particular scenario, we're going to discuss aircraft pressure changes and how those changes affect the inner ear and become problematic. As a result of these pressure differences between the inner ear and the outer ear, there can be actual physical damage to these structures. Going back to my anatomy lab when I was a first year student, these structures are frail and they are tiny. As you'll see in a few slides, how delicate these structures are. These pressure changes create a vacuum which causes a retraction, if you will, of the eardrum. This retraction puts pressure on those structures, compromises the function of the eardrum, compromises hearing, and can be very painful. At times, there are fluids within the ear and behind the eardrum. If you have allergies, sometimes your head will get stuffed up, or you get a middle ear infection. That middle ear infection is called otitis media. That means there is inflammation of the structure of the ear behind the tympanic membrane. And this is a function of too much fluid, more than the eustachian tube can drain off of the system. The findings must be consistent with the reported event, and if untreated or not treated quickly and appropriately, can result in a permanent hearing loss or, at times, significant chronic pain. So here is the structure of the ear. And as we see here, here's the ear canal. This particular canal, nice and clean, not loaded with wax and all the other debris that can occur. You should know that in some individuals, these ear canals have a lot of hair called cilia, can become impacted with wax. You can find videos online and on YouTube of people who just make a career disimpacting the wax here. And the skin along here sloughs off and can collect. If it's not appropriately irrigated, treated in the shower, make sure the water only. The ENT guy I had said the smallest thing you should put in your ear is the other elbow on the backside. This is a caution against Q-tips, paper clips. You'd be surprised at the number of structures and implements that are used to clean out the ears. As you can see, this is the eardrum, also known as the tympanic membrane. And basically, kind of like the surface of a drum, the sound waves come in, cause this to vibrate. These vibrations are picked up by these structures here, these fine bones called the cochlea, and then the cochlea transits via this process here to the nerve, and then hearing is perceived in the brain. So technically, you don't hear with your ear, you hear with your brain. It's just that this mechanism is required to make that happen. As you can see behind the eardrum, fluid can collect. Sometimes this is clear, sometimes it's infected, it's purulent, it's very thick. And when it's so thick and purulent, it's not able to drain via the eustachian tube. And with that, this gets clogged up, this becomes inflamed and red, infected, etc., and becomes problematic. Therefore, when you have pressure changes and the pressure between this tympanic membrane and these structures cannot modify themselves secondary to the environment, then it becomes a problem, and it can become a traumatic event, also known as barotrauma. For the purpose of this talk, obviously, we're going to focus on aviation, and most often a rapid altitude change in cabin pressures. For whatever reason, the pilot decides to descend 8,000 feet. We all heard about that story in Singapore a few weeks ago when there was a huge 6,000 foot change. That's more than a mile. That's a long way down. That's got to be one scary situation. In any event, the altitude changes result in pressure changes. Those pressure changes, depending on the fluid that's present or not, with behind the middle ear changes, and that becomes the location of the symptoms. This kind of injury can occur with diving, deep sea divers, when there's rapid ascents and descents, or breath holding. I had a friend a few years ago, she was the world record holder for free diving. I don't know if you know what free diving is, but these individuals go to a very deep spot in the ocean, they hold on to a very heavy rock, and they go down. And then by holding their breath, they go down a certain depth, and they swim back up under controlled circumstances, and hopefully the eardrum kind of pressurizes out and it's not a problem. However, if they decide to come up too fast, the pressure changes between 200 feet of depth and 25 feet of depth of water are significant and can cause significant compromise to those eardrums. I don't know why people competitively hold their breath, but I did see online the other day, there are people who smack each other upside the head as a competition. I have no idea what that's all about, but it's out there. And then if they're doing some diving and they have appropriate equipment, and if there's an equipment failure, that's another cause of the identified barotrauma. There are certain medical procedures that can lead to barotrauma. If you have a young child who has chronic ear infections and they decide to put a tube into the eardrum and there is allowing the fluid to escape, not via the eustachian tube, but via that tube that they put in, again, it keeps the pressure same and keeps that child less symptomatic. But there are other medical procedures that could occur that do that. As I mentioned earlier, there are those individuals who remove tons and tons and tons of earwax. And if you're not careful, in some individuals whose ear canal are tiny or they did not be paying attention, those instruments can compromise the tympanic membrane. And lastly, hyperbaric oxygen. Those individuals who have some difficulties getting rich oxygenated blood to the lower extremities, or for some other reasons, they go into a hyperbaric oxygen chamber where the pressures are really hot. That's the hyperbaric oxygen. And that can also, a noted complication is the identified barotrauma. And then there's environmental changes, weather. If you happen to get sucked up in a tornado, whoa, that's going to really change things. Or explosions. There are people who are near quarries or petrochemical plants, and those explosions, when an explosion occurs, the air gets sucked that way, the air pressure changes violently, dramatically, and that also can be causative of the situation. The point of this is that when you are talking to that individual who's alleging an ear problem, you need to identify what activity was happening and is there a history of diving or other medical procedures, etc. All these data points should be addressed in the in your assessment of this particular injury. There are common symptoms and uncommon symptoms. Let's go with the common ones first. Ear pain. Who has not been on an airplane when the pilot descends and your ears get plugged and, oh my goodness, this hurts? Or that little baby who's not able to modify the eustachian tube dysfunction and things like that, and you hear them crying all the way down because their ears are hurting. So discomfort is probably the most common diagnosis. Very commonly, you get what's called a stuffed sensation, a feeling of fullness. There is fluid behind that tympanic membrane. The tympanic membrane gets retracted, so the space available is decreased and the fluid pressure goes up, and you get that fluid feeling. When people pinch their nose and breathe and blow out, the Valsalva maneuver, that's trying to address that stuffed sensation. With that procedure, basically the fluid is forced through the eustachian tube. The fluid is gone, the pressures come back to normal, and you do well. But it doesn't always work. And there's an urge to depressurize, as we talked about a moment ago, the Valsalva maneuver. You want to pop your ears. I think in my personal situation, the worst one, the pilot had to come down relatively quick. Don't know why. He landed, we got off, and my ears didn't clear till I cleared the parking lot and driving home. But it can take that long, 10, 15, 20 minutes, and in some cases even more. There may be a mild temporary hearing loss. As I pointed out earlier, the hearing is a function of the vibrations against the tympanic membrane, those vibrations going to the bones, and the bone's turning that into electrical pulses, and the optic nerve, I'm sorry, the otic nerve takes it up to the brain, and that's where you hear. So if that's not functioning, you may lose the ability to translate those pressure waves and so forth against the tympanic membrane, resulting in a temporary hearing loss. The more severe signs, extreme pain and pressure. We all know pain is very subjective. One man's number 2 is another man's number 10 pain. Why? I don't know. I know that some guys are more stoic than other guys. All I know is that I could play racquetball for an hour with my buddy, beat each other up, we're beaten, bloody, and we had a great game, let's go drink a beer. But if my wife thinks about stubbing her toe, I'm doing the vacuuming for 2 weeks. I don't know why. Her pain tolerance, isn't there. Another severe sign is the identified vertigo. Vertigo, dizziness, that spinning sensation. Again, those are all findings of those small, frail bones I pointed out earlier not doing their job. And with that, you get sensation. You get the ringing in your ears. You get the dizziness. All of that, the spinning sensation. All of that happens because those structures are not functioning as indicated, and that's the response. That's what happens. Kind of like if you hear that thump, 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 and your back tire is gone flat, then you know that tire is not functioning. So you get that kind of symptomology. In very ultimately severe cases, there can be hemorrhage or bleeding. There was a case, I think it was 4 or 5 months ago, and the adjuster was unsure if there was barotrauma, but I read the physical examination, and they said there was significant hematoma. A hematoma, by definition, is a collection of blood, and you get a collection of blood because of trauma, and there it was. So in this particular situation, there was significant hemorrhage and bleeding. It was a no-brainer. There was a compensable barotrauma in that scenario. And again, hearing loss, a more significant hearing loss that does not come back. That would be considered a severe sign. When you are dealing with these individuals, it is imperative that you get a very detailed, accurate, and supportable history. This is paramount. Most of this happens at altitude at 35,000 going down to 20,000 or whatever the scenario is, and you need to know what's going on. If need be, go get the flight records and find out, did this really occur? Not everyone who has a stuffed ear or ear pain has sustained barotrauma. There has to be a reason why, a specific, compensable, and objectifiable clinical event, so that I know this individual has reported a claim, has gone to the initial clinical evaluation, be it an occupational medicine clinic, a doc in the box, a local provider, or whatever the scenario might be. All too often, they do not provide you with a detailed history. After we complete this talk, and we'll make this available not only to you guys, but to the rest of your teammates, is it'd be a roster of questions that you should ask every injured employee alleging a barotrauma. This will help you augment what the treating doctor has gotten and help you get all the information necessary so you can make the best possible determination. An additional document we'll be sending out after the completion of this talk are data points relative to what should be in the initial and subsequent physical examination. When you see the list, you're going to kind of understand why not every data point is made, but each point is important and you need to have it, particularly when there are some gray areas, or it could be this, that, or the other thing, as we'll see in an example in several minutes. And was there a rapid change in air pressure? Secondary to what specific event? And again, the flight log will tell you, or I'm sure that the flight attendant will talk to the pilot. What happened? Well, this other plane cut to our airline and we had to go dodge the plane, or there was a huge downshift. The air draft and the storm can cause aircraft to descend fairly rapidly, fairly quickly. But the pilot, I'm sure that the injured employee has talked to the pilot to find out what's going on. If you can find out what's going on to back up the claim, this would be very, very helpful to anybody reviewing the file. Did the change occur faster than the body could adopt? That simply means that if it's a routine normal landing, chances are it's not a barotrauma. This is probably somebody who has a middle ear infection, otitis media. It came down a little bit of pressure, and all of a sudden they've got a complaint. But was there really a barotrauma? And that's a question to be sorted out by appropriate history, detailed history, and a detailed physical examination. Is there a history of allergies? I know that my wife is really, really allergic to cedar. She won't fly in December. When cedar fever comes in, she's parked. See you later, or we're driving. She won't even fly to Dallas, and I'm in Austin. It's that bad for her. So ask the question, is there a history of allergies? And here's additional questions that more probably than not are not asked at the time of the initial clinical evaluation. So ask, do you have a cold? Is there a rhinitis, runny nose? Is there asthma? Any other neurologic disorders? Any rheumatologic disorders? Ask all these questions. Is there a prior history of tinnitus, vertigo, hearing loss? Hearing aids. You know, I wear my hearing aids sporadically. My wife would like me to wear them more, but it's kind of uncomfortable. But I do need to wear hearing aids. Regular headphone use. I'm astonished that there are some people who crank those headphones up so loud, I can hear them, and I'm 2 seats away. Imagine if you're behind those eardrums. They're just assaulting your eardrums and assaulting your hearing system. With that, that could be the cause of the identified trauma. And I asked them, is there any prior history of ear pain or other ear issues? As you can see, there are a number of questions that probably were not asked during the initial or subsequent examinations, which it would behoove you to get this information, particularly if you're going to have an otolaryngologist and ENT guy review this. These are all questions he's going to want to know and make it happen. Lastly, is there an aspirin sensitivity? You know, some people have that. And the running joke is that if aspirin were introduced today, there's so many side effects, it probably would not get approved by the FDA. It's simple as that. But we've been taking aspirin for the better part of a century and a half. You know, and lastly, are there any medications? Medications have untoward effects, and some of these effects can affect hearing and the issues related to hearing, like tinnitus or vertigo, etc. So maybe the issues being sustained, many of the issues noted, are a function of the medication they're on and not because they were in an aircraft. Tobacco use. I'm not a guy, I've never smoked cigarettes. You know, I'm not a tobacco guy. And more people are in that club. I go back to when I was growing up, went in the military right after high school, and they gave us a package of 3 cigarettes with every C ration we got. So with every meal, we got our 3 cigarettes. I didn't smoke them. I traded them off to other guys who did. But there was a lot of, fortunately, the number of people consuming tobacco products, I should say, consuming tobacco products is dwindling. It's less than 26% now. You know, back when I was growing up, it was closer to 50%. You know, in 1964, the Surgeon General said tobacco's a bad thing, but it's still around. And ask that individual, what specific actions did you take to address the noted symptomology? You know, plane came in, my ears popped, I blew them out, Valsalva, it's better, but it's still hanging around a little bit. Or I did Valsalva 32 times, nothing happened. I was dizzy coming off the aircraft and I had to hold my hand up or whatever. But these are key historical issues that would really help you, the otolaryngologist who's assisting you, or the hearing officer to decide, was there in fact a barotrauma? Where was the onset of symptoms? I noted it when the plane was in its descent for its final approach. What specific part of the person, right ear, left ear, was it both ears? Are there any other symptomologies noted? You know, again, these are seemingly minor issues, but when you put them in the aggregate, they become significant. Were there any head and neck symptoms noted pre-flight? Yeah, I had to take 6 over-the-counter decongestants for my allergies. I had a head cold and I'm sucking down whatever medication to dry myself up. Now, if you think about it, when you dry yourself up, that goo behind your ear that takes the water out, that becomes even more problematic and it becomes more viscid and it won't go down the station tube. So that again says this is a pre-existing condition, and there's no evidence that my event made it worse. Again, this could be huge. Ask them how many ascents and descents were completed during this particular work shift. You know, if you're flying from New York to California, chances are you're going up once and down once. But if you're going from Austin to Dallas to Houston to New Orleans, you're up and down 8 times in a 8-hour day, whatever the case may be. So again, these are the kind of things that should be on their record. You should know, and it gives a better sense of what's going on. Did that injured employee have any issues noted with the landing? Yeah, the pilot landed really hard, or he almost skidded off the runway, or whatever the case may be. But all these things add to the overall mix and need to be addressed at the right time. Is there a history of eustachian tube dysfunction? This kid had tubes in his ears when he was 13, or he had chronic ear infections over the last 5 years and he had a surgical intervention. Are there tubes or other pathologies? You know, there's a million things that go wrong. Otolaryngology is its own medical specialty, and that's just the head and neck. That's what we're talking about. Nose, mouth, ears. You know, otolaryngology, that's it. Not a lot, but there's a lot of things that can go wrong. And you take someone who really knows what's happening to sort all that out for your benefit. I mentioned earlier the Valsalva maneuver. You know, it's easy. You pinch your nose and you blow out. And what that does is it increases the pressure behind your eardrum, forces the tympanic membranes to bulge out, and the fluid that collected to go down the eustachian tube. Whatever's blocking the eustachian tube, hopefully the force of that will be taken out and taken away and allow for drainage. I don't know how it happened, but I found on my Facebook page these guys who go and break up beaver dams. And I find them fascinating how a beaver just gnawing down trees can put together these structures. And some are tiny, 2 or 3 feet, but some are huge, like 20 or 30 feet. They pack them with mud and the sticks and everything, and it builds up a huge dam. But once you break down that dam a little bit and take a 2-foot section out, here comes the water rushing out and the whole dam goes downrange. So that this is what the Valsalva maneuver is doing. And it's increasing that pressure to clear out the eustachian tubes and hopefully make that individual symptomatic. Is it always successful? No. I mean, as I mentioned earlier, I did it one time for myself 2 or 3 times. My ears didn't clear till I was, past the parking lot on my way home. So it can be more severe for some people. The next part is the physical examination. If somebody gets sent to an outpatient clinic, a doc in the box, whatever, it's incumbent upon that provider to do a detailed physical examination. Unfortunately, in the records that my ENT guys look at, and I'm the point of contact for these guys, so I hear about it. These guys call me up and it's, Whiskey Tango Foxtrot, who is this guy? How can I make a decision? Yada, yada, yada. And I agree. But we do the best we can with what we have. So the purpose here is that one of the handouts you're going to receive at the end of this talk is a list of items that should be in the physical examination. If these issues are addressed, it's going to help you make the correct decision so much quicker. And that's the important part. So there needs to be direct visualization, and we'll see a slide in a minute as to why. A discussion about the pinna. The pinna is just out of the outer part of the ear itself. This is the pinna. Okay. Then the canal. We talked about the canal. The sound waves go there. There's a waxy substance. It's called cerumen that can build up. I've seen it from mush to hard as nails and like slate. It's astonishing. The amount is unreal. Too many people, they stab a Q-tip in their ear and they just pack it down. So you can imagine having all this earwax packed against the eardrum. I mean, there's studies where a guy was reportedly deaf for 6 years. They took the earwax out and it was a miracle. He could hear. Well, yeah, because the sound waves can get to the eardrum. Eardrum can do its thing and see you later. The tympanic membrane has to be discussed, and there's certain key points to that discussion. The cone of light, the structures, any fluid, any bubbles, things like that. And part of that examination, when they take that otoscope and they turn it upside down, the light goes down the ear canal, there's supposed to be a little red bulb, and you squeeze it. And the idea here is a little brush of air goes against the eardrum to see if is the eardrum moving. There are some situations where the eardrum can be scarred and not move and not meet its function. Or, as we'll see in a moment, it can be traumatized and there could be blood behind it or whatever, i.e. a barotrauma. So therefore, we really want to know what the focus here is. And it's one of the list of items you're going to have to, even if it takes you calling that doc, that chiropractor, that PA, nurse practitioner, whoever, and say, dude, really? What about A, B, C, D, and E? And they should respond, email or writing or somewhere, oh, this did or did not happen. But hold their feet to the fire. Make them do their job. I mean, if it's an emergency room, what are they going to charge you? $2,000, $3,000, $4,000? You know, this exam takes 15 minutes tops. For that kind of money, they should do everything they're supposed to do, be detailed and be thorough. It's not that hard to do all this. I've done it many times. My 2 months of being in an emergency room for kids. Oh, I was thrilled. Try and hold stick a light in a kid's ear and hold him so he's screaming and crying and wriggling all over the place. That's a joy. Another reason why I did orthopedics. But that goes there. The examination, is there evidence of trauma? And trauma can be swelling. The tissues can look puffy. Is there a hematoma, a collection of blood, or other indicators of pathology? Have they described the anatomic structures behind the tympanic membrane? As we'll see in a moment, there's a couple that need to be discussed. And is a cone of light visible? The cone of light is a reflection off of the tympanic membrane, just the way it's normally shaped. That's a good thing. If they got a good, healthy cone of light, then we're happy campers. And are there bubbles? If there is an infection or a fluid collection, has some air got trapped in there, and that become problematic. And that would be another indicator of trauma. So here we are. Here's the tympanic membrane. The person's nose is over here, and you can see here's the ear canal. And this one, I chose this one because it's pristine, perfectly clear. There's no earwax. And I'm here to tell you, you do this. I can't understand why that did that. There's no earwax. I can't tell you how many times I look in there and you just can't see anything because of the earwax or trauma. And whatever foreign object, to include insects. All that stuff can happen, but this is a normal, healthy ear. So you have the incus, it's a little tiny bone right back here, and you've got the malleolus, okay? And this is the long process of the malleolus. So these two bones, the eardrum absorbs, if you will, the sound waves and vibrates, kind of like when you hit a snare drum, right? The surface of the drum vibrates. Those vibrations are then translated to those bones, the malleolus and the incus. And I'm here to tell you, when I did my anatomy class, we had to dissect that out. These are tiny. They're just little tiny bits of bone, and it's just really, really difficult to make this dissection. But this is where the sound waves come in. And the sound waves go here, and these get transmitted, we'll see in a moment, or if you saw it in the prior slide, I should say, those go to the nerve, and the nerve takes to the brain, and all of a sudden you're hearing, okay? So we have all these structures, but all of these have to be addressed as part of the physical examination. So here's our talk, guys. Here is an otoscopic view of a barotrauma. Now, you can see there's a cone of light, so this eardrum is relatively healthy, but look at the canal here. There's no wax, but there's markers. Somebody traumatized us. Was this a Q-tip, or was this air pressure? We don't know. But what is significant here is look at this collection right along here. This is a collection of blood. That is a hematoma. There was a traumatic event to this ear. And if it's tied into an aircraft that descended 4,000 feet or whatever, and this happened under the concept of liberal construction, these findings with those symptoms, and assuming all the other history questions are answered appropriately, then yeah, you've got a barotrauma and you've got to treat it. Now, in this particular case, the treatment is relatively conservative, and all this will resolve probably within 3 to 7 days, okay? Other situations, as we'll see in a minute, much different, much more severe, and will cause a lot of different issues. But you're going to see changes like that, and is it yours or not? And that's the question. That's why we go to that history. That's why we go to that physical examination to match it up with this. If they all are consistent And it makes clinical sense that absolutely you take care of that guy. That's what you're here to do. You're here to take care of compensable injuries. But in this scenario, when you got these kind of findings and the person hasn't flown in 8 days, then you got to think about, well, maybe there was a Q-tip or a paperclip or a key or something else that went into the ear. I'm not saying there was, but it's a consideration. And then, of course, there's the all-famous punctured ear. And as you can see, you really don't get a cone of light. The eardrum is puffed out. Okay, it's not against those structures. And there is a big old hole right there. That is a perforated eardrum. Happens frequently, for any variety of reasons. One of the interesting things with this particular view is, I hope you can appreciate that, but these margins of that puncture, they're being pushed inside the ear. Had this been a puncture because of increased pressure, then the margins would be coming out towards you. So this is a situation where I would bet, again, this is a slide I found, I would bet that this was somebody who tried to clean his ear with a Q-tip and perforated their eardrum. If there was a fluid collection back here and it came out towards you, then you would see debris here, fluid. Sometimes it gets crusty, but you find that you wouldn't find this pristine ear. This is a potential surgical lesion. A perforated eardrum that size, treatment is oftentimes conservative to include patches and the eardrum heals in a day or two. If not, because of the size or whatever, and it's been a week, then that may require surgery. Again, I'm an orthopedist, not an otolaryngologist, so I really can't speak to that. But what I can tell you that if you've got a perforated eardrum, let's take a peek at it and see, does it look like there was fluid coming out, or was there an object going in? Look, there's a little bit of injection here, but no other signs of trauma. You got to wonder. That's all I'm saying. You got to wonder and apply the standards of evidence-based medicine. Let's talk about the physical examination. Unfortunately, it is a detailed clinical examination, part of which includes what we call the Rhines test. And Rhines test is the tuning fork. So you bang on a 256 hertz tuning fork, you bang on it on your elbow or whatever, and you put it behind the ear and hold it in front of the ear. And that's testing here on the left against the ear. This is called bone conduction. Over here in front of the ear, that's air conduction. Does this person, can he hear that 256 hertz eardrum equally between the two? Or is the air much more, or is the bone conduction much more? And that is hugely important to the overall clinical assessment of what's going on. This is for the otolaryngologist to sort. And then there's Weber's test, again, using the same tuning fork, but you put it in the middle of their forehead. And the question is, where do you hear it more, on right or left or in the center? Okay, and that'll tell you the neurologic aspects of the hearing functionality. Okay, there you go. Additionally, with the physical examination, there's a test called finger rub, and it is simply just that. You take your index finger and your thumb and you rub them together. I would tell you that I had a head cold, and I was just lying in bed and being what every husband does, feeling the whole world is against me and I'm the sickest person in the world, and it was just a head cold. My wife told me to get out of bed, but that's a whole separate conversation. But I rubbed my fingers and I couldn't hear anything. Nothing. Okay. So I called my buddy, the otolaryngologist, said, Pete, yeah, head cold, rub my fingers, hear nothing. He said, come to the office now. I'm here to tell you, when your friends tell you to come to the office right now, it ain't good. Okay? He doesn't want to see me right away, but he said, oh, no, you got to. It turns out I had a viral infection that compromised the nerve. And everything we tried, steroid injections and medications and all that stuff, it didn't work. That viral infection, that benign head cold, left me deaf, complete 100% deaf in my left ear. In fact, when I was getting tested by the audiologist, she could hear it outside the hearing booth before I could. I mean, it's just like, I can't hear jet engine noise deafness here. I can hear on this side, but not over there. So you want to see the finger rub as part of the physical examination. Additionally, while they're doing that, you want to make sure they talk about the cranial nerve number 8. There are 12 separate cranial nerves, all with very different functions. cranial nerve number 8 addresses hearing. So part of the physical examination has to include a clinical assessment of cranial nerve number 8. Sinus percussion. People get sinus infections, and you just want to take your middle finger and beat on them, up here on the forehead, on the cheeks, over here. Do they have a sinus infection that's draining through there, causing the noted pathology or symptomology? Okay, that's part of the testing. Listen to their lungs. If they've got 2 lungs full of water or pneumonia or whatever, chances are that pathology has migrated up to the ear and is causing the problems, and not because they've had an acute barotrauma. After you complete the history, the detailed history, and the very thorough physical examination, the next testing that's done is called a tympanogram. This is a study to measure the functionality of the tympanic membrane, the eardrum. And there are 3 kinds to do that. So the question becomes, what category of finding is recorded on the tympanogram? Is it type A, type B, or type C? The authors are very original. There you go. Okay. And you have to ask yourself the question, what specific skills does the operator of that device have? Or is it just like they grab the radiology tech to come over and do that? Because if it's not done correctly and you get incorrect results, you could be chasing down the completely wrong path. Additionally, there's laboratory studies, CPK, creatine phosphokinase, and CBC. The CBC is looking for the white cell count and the red cell count to see if there's infection, and the phosphokinase is to just like other liver functions, other parts of the process are in place. But those are the 2 basic liver studies that you should have in your record. And in very severe cases, plain films. Was there a fall? Is there trauma behind the ear to the skull or the head or whatever? And plain films will resolve that. I'm not saying CT scan or MRIs. No, plain X-rays. Okay, as simple as that. You want to make sure there's no specific traumatic lesion causing the noted symptomology. With respect to tympanograms, again, we have type A, which is normal middle ear functioning. The tympanic membrane is doing its job, the fluid's not collecting, and you should be hearing things. Yay, this is what you want. Or, get a normal pressure. Or B, then there's fluid in the middle ear. That's called an effusion. Kind of like a knee effusion or whatever joint, there's a collection of fluid behind the tympanic membrane of that structure and the bony structures. And the fluid can't escape the eustachian tube. It collects, it gets hard or crusty or whatever, and it becomes very problematic. And the findings on tympanogram, if there is a specific injury talked about, if there were specific findings noted on physical examination, and with this, then you go, you're golden. Yes, I'm sorry that person had a tympanic membrane injury or barotrauma, but at least you know what you're dealing with. And as any otolaryngologist will tell you, start the treatment as quickly as possible. Make the accurate diagnosis and apply the most appropriate and accurate treatment plan mitigates any complications. And dealing with the head and neck, the complications can be rather significant rather quickly. Again, there's no identifiable peak because there's fluid behind the middle ear, and the ear canal itself appears to be of normal volume. And the last one is type C, which is demonstrative of eustachian tube dysfunction. Let's go back to that first slide we talked about, and that little tiny eustachian tube, there's areas that it gets very narrow. And if the viscosity of the fluid is increased because there's bacteria and other material in the fluid, and it just doesn't drain, then that becomes really problematic really quickly. So here are the 3 different types. As you can see, type A, going to 0, it goes up, then it goes down. Everybody's happy. Type B, it kind of stays the same. There's no, the eardrum not doing its job. And then there's type C, sharp onset and a prolonged descent here. Again, pathology B, pathology C. There are 2 different variants, type AS and type AD, that are on the slide. But again, that's for the otolaryngologist to sort out, not for you guys to sort out. As I mentioned earlier, we're going to give you a list of specific data points that are absolutely necessary in the medical narrative. It is a pain in the tuchus to do it all, but you have to demand that. To do your job effectively and thoroughly and in the best interest of that injured employee, let's get the right diagnosis as quickly as we possibly can to start the most appropriate treatment plan. If it's yours, and take care of it. If it's not yours, that's a whole separate conversation, okay? But if the team member complains of ear trauma, barotrauma, issues with tympanic membrane, sinus infections, whatever, you want to get this resolved as quickly as possible. Again, the sequelae can be particularly harsh if left untreated. In the next couple of slides, we're going to talk about the specific questions you want to ask, the specific findings you want to see on physical examination, and should be absolutely completed with the initial clinical assessment and subsequent evaluations, particularly by the otolaryngologist. Most ENT guys they just know it. It happens so frequently, it's there, bang, and they tend to skip over all the things that you might need to know because they're treating this guy and it's there. I could tell you that if you came to me with complaints of knee pain, and when you went to church on Sunday and you knelt down and it hurt, or when you're walking down a hill, your knee hurts, I'm like 99% certain you've got chondromalacia patella. That's in my wheelhouse. That's what I've been dealing with. But I owe it to you and everybody else to say, here's the physical examination, here are the x-rays, here's why he has this diagnosis. So that's the point I'm trying to make. The oral ENT guys, they're going to know this stuff in a heartbeat, but they have to give you the data because you're not an ENT guy and you don't know it in a heartbeat. You have to do your job maximally and efficiently, and you need the information to make that happen. Again, we talked about a very specific detailed history with very specific symptoms and a meticulous narrative report of the offending, right from the offending event, the aircraft was knocked down or had to dodge somebody or whatever the case may be. I am sure the flight attendant talked to the pilot when the plane landed to find out, que paso, what's happening here? And the pilot probably will tell her. Anecdotally, but again, it needs to be part of the system. And then there has to be a comprehensive otologic history. And you need to answer the questions 1 through 10, as we'll hand out at the end of this talk. A thorough examination to include visualization, the tuning fork, auscultation, finger, all these topics need to be addressed. You can't just say, oh, I saw his ear and there was some gunk in it and he had barotrauma. That's not going to cut it. They all have tuning forks, they all have the otoscopes, the little rubber ball, because this is their livelihood. There used to be the running gag in cartoon with the physician with the mirror on their forehead and has a hole in the mirror. That's specific to ENT. Those guys have a light over the person. They put that light into that mirror, they put that mirror around, and they can look and see things, and that's what that light is for. Not too many otolaryngologists wear it. A buddy of mine does. He looks goofy, but he wears it all the time because that's one of the tools they use to develop that. Do a detailed, thorough job. I tell docs all the time, do the physical examination you did your first week of medical school. And we're all guilty of that. We wrote these hugely detailed, talked about Mongolian blue spot fever and all this nonsense, really not germane to a knee injury, but that's how we were trained. And you want that first day of ENT residency type physical examination. Cover everything. If it's negative, say so. But if it's positive, say that so that you and the reviewer, if there is one, the ENT guy, or the adjudicator, the hearing officer, he'll know this is a very detailed examination. They made their case. Here's the evidence-based medicine. Bang, he's got a barotrauma. And that's okay if it's there. But if it's not there because he just has an earache, that's a different enchilada. And note the findings on tympanogram as well as the laboratory studies and x-rays, okay? All this goes into it. This is a tad redundant. I really wanted to stress that a complete comprehensive otolaryngology physical examination to include tuning fork. Are there any other sores or lesions noted on a clinical assessment? Was there a cranial nerve assessment? And these are things we see, or more importantly, we don't see frequently when we're doing these evaluations. Okay, these are the complaints I get from my guys who are doing these reviews. And, they're frustrated. I get it, but like, they're, in my mind, almost embarrassed that an ENT guy would do an examination and leave out 2/3 of the data necessary. And he calls himself an ENT guy. I'm an ENT guy and I do my job. You're not doing your job. And it's like that with just about every specialty in medicine. Okay. Was there debris? Was there discharge in the external ear canal? If there was discharge, is it secondary to a ruptured eardrum? Is it secondary to some other event? The guy, scratched his ear with his toothbrush, scratched the canal and it got infected. Okay, clearly not a function of the injury, but injuries like that do occur. We talked about the Ryan-Weber test. Does the sound lateralized? Identify specific findings relative to tympanic membrane. If there is fluid, is it clear, bloody? Does it look like it's infected, or other findings? Again, a skilled, experienced otolaryngologist or even an ER doc will talk about these stuff. And they have to talk about this stuff. It's the lazy guy who doesn't, and that puts you in a very difficult situation. Is there a hole in the eardrum? As I pointed out earlier, I showed you a giant hole in the eardrum, but it clearly looked like it was not an explosion where the fluid came out, but it was a perforation where it went in. Somebody probably perfed an eardrum secondary to a Q-tip or something to that effect. Were there bubbles present and the light reflex? Again, these are the kind of things that would be on every examination. I'm taking my ENT boards and I'm being asked by the reviewer, okay, what should be here? I need to say all this. That's the standard. The literature I went to, I visited, these were the findings on multiple citations of what incorporates into that physical examination. We talked about the tympanogram, A, B, and C. How do you, and again, it's like radiographs. Some guys say, oh, this is a B because, and there's obviously shades of gray. And some guys are a little more liberal, some guys a little more conservative. How do you define a positive tympanogram? That may be a question asked. If everything else is negative, no history, no finding of fibular limb, but there's a positive tympanogram, wait a minute, dude, how did you get there? It's like, I can remember back in the day when we see these EMGs, normal, 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 positive for carpal tunnel syndrome. Why? Because the guy doing the EMGs wants the referrals from that surgeon, and if he doesn't send him some surgery back, he ain't getting them. That surgeon's going to find some way to bury that data. Or it's kind of like impairment ratings where, wait a minute, he's not at maximum. Why is he not at maximum medical improvement? Well, he only had 15 sessions of physical therapy and not 16. That's no reason, but some people use that. You want competent, objective, and independently confirmable medical evidence. That's the standard you have to apply when you're doing this, and the question that needs to be asked, okay? Next question I see is, when can this individual return to work? Well, that's based on the pathology. What's the clinical basis for this determination? If this guy had a ruptured eardrum and there's a bloody fluid running out of his ear, yeah, he ain't going back to work for a while, guys. How severe is that puncture? Does it require surgery? All those questions have to be answered before that. If it's a minimal barotrauma, like the first slide I showed you, yes, there was hematoma, yes, there was a barotrauma, but chances are that whole thing would probably resolve within 3 days. Again, I don't know that for a fact because I found the slide for demonstration purposes, but why can't he go back to work? Now, would I put him back to work flying up and down? Probably not. But if they could go to work answering telephones or some other meaningful work relative to their job, sure, why not? So again, it's a valid question we're asking. And if you're not sending them back to work, tell me why. I bring that up. This has happened a number of years ago, and some of you guys may know the story. A woman flew from New York to Paris. She gets off the plane in Paris. She has ear trauma. The physician in France said, you can't fly for 2 weeks. Why? That wasn't clear. He just said she can't fly for 2 weeks. So we get to put her up in a hotel in Paris and feed her for 2 weeks, and she's on the clock. Yeah, I got to get me a job like that. I would love that 2-week paid vacation in Paris. Yay! okay? But otherwise, it's not happening. And again, is some kind of an additional consultation of otolaryngology assessment is necessary. There are those providers in doc in the boxes or occupational medicine clinics who try to manage it themselves. I'm here to tell you guys, there's so many complications that could occur, and it's better if there is any hint of a barotrauma, get them to the right guy, and that right guy is an ENT otolaryngologist. Again, my ear, finger up negative, I call my ENT buddy, boom, I was right there. Unfortunately, it did not work, but it could have, and I was right there right away. So, think about that. You need the right guy to make the right call. The treatment could be as limited as decongestants and analgesics. Let's make that fluid behind the tympanic membrane very viscous. It goes down eustachian tubes. Yay, raw, it's gone. A little pain pill over the counter, or maybe a prescription strength non-steroidal. Again, taking the inflammation down, taking the pain issues down, makes the overall situation better. It could be that limited. If the eardrum is ruptured, like we talked about in that previous slide, surgery has not been ruled out. Again, an ENT needs to look at it and say, yeah, I can treat this with a patch, or I can do this or that, or you can say, no, this is a bad one. I got to take this to surgery, and there you go. But finding out sooner rather than later is paramount, and that's what you really need to have. If there is a pulmonary compromise, there are occasions when oxygen may be necessary. Okay, probably not as a function of a barotrauma in a flight attendant, but if it gets to your desk and it does get accepted, you cannot rule out oxygen therapy until the right person takes a look. Complications can go from chronic pain. And I've read cases, when I'm preparing for this talk, I've read about different cases where the pain went on for years and severe unremitting pain. And when I saw the pathology reports, like, yeah, this guy's ear is hosed, completely hosed, and he had a basis for those pain complaints. Persistent hearing loss. Now, hearing loss in one ear, a little pain in the tuchus, but it's not doable because you got the other ear. But if you had another trauma and all of a sudden you're deaf, I'm here to tell you, that would just cripple me. Not being able to hear my own voice, I'm out of control. Nuts. Not being able to go to the movies. I'm not a big fan of reading the lines. You don't get the syntax and all that stuff. So persistent hearing loss could occur. Again, with chronic pain and persistent hearing loss, long-term medical care. Hearing aids, cochlear implants. Yeah, and if you want to go price out cochlear implants, that's a big number. And then lifestyle adjustments. If I can't hear, or I can't fly, or whatever the case may be, those are all noted complications to this particular pathology. So we've gone through a talk, we've got a few minutes. Chelsea, were there any questions posted?
Not yet.
Not yet. If anybody has any questions, please feel free now, or give me a call. My phone's with me all the time, 512-750-5900. Or you can send me an email. There's my email address, dabrams@comp-consultant.com. And again, I want to thank you guys for the time. I know we've been an hour here. I tried to get through a bunch and make it as detailed as possible. Chelsea will be sending you out. We got your email addresses, and she'll send extra copies out. But we want you to have the list of questions that you need to see in every history that you obtain. Because if you're obtaining it, you got it. It's there. And if you have any questions about the veracity of the answers, you can do that. And the data points that the clinicians need to complete. If they're not there on the first time, send them an email, send them a snail mail, give them a call, whatever. Get those data points filled. With that, I'll say goodbye. Enjoy the rest of your afternoon and have a great week. Talk to you guys soon.
Thanks, Don.